teammates. I've been chatting away here, and apparently nobody could hear me, so I'm just going to start again and welcome you all to our this is the second Knowledge Hub and Learning Network webinar. And today's webinar is on what it takes to become a trauma-informed organization. We're really pleased to have as our presenters Holly Murphy and Sue McWilliam. And while I'm not going to read their bios, I do want to let you know that Holly is an advanced practice leader for trauma-informed care at the IWK Health Center and co-lead for the Building a Trauma-Informed Practice Framework in Nova Scotia. And Holly believes that we all play a part in creating trauma-informed environments with our clients, families, staff, and systems. Her co-presenter, Sue McWilliam, is an advanced practice leader for outcome and evaluation research for the Mental Health and Addictions Department at the IWK Health Center. And Sue's past involvement working with street-involved youth fuels her passionate support for the adoption of a trauma-informed approach at the IWK. Our presenters will speak for 60 minutes, and we'll then have a question and answer session for an additional 15 minutes. What we would ask you to do is during the presentation, if you have any questions, please write them in the chat box that's on the left of your screen, and our team will monitor the questions and select as many as we can to present to our presenters to answer in the additional 15 minutes after their hour presentation. We also wanted to let you know, because we get lots of questions about this, that the PowerPoint slides and the webinar recording will be posted on the Knowledge Hub and Learning Network website within a couple of weeks after this webinar. So you can take notes, but you will have access, thank you to the generosity of Holly and Sue, to follow up with the PowerPoints later. We also wanted to let you know that your feedback and input really help us design and plan future webinars. So at the end of this webinar, Sarah will be sending out a link to everyone with a very brief evaluation form. And we would invite you to complete that form. And we just want to assure you that we look at them very carefully, and we do use them in our planning. So with that, I'm delighted to turn it over to Holly to make our presentation.
Okay.
Hi, everyone. Thank you so much for having us. So I'm Holly. I'm Sue. As we get ready in the frame here. So thanks so much to the Knowledge Hub for reaching out to us, and hopefully today we'll get to share some of our experiences as we try to become a trauma-informed organization. And it is definitely a process and a culture shift for us. Okay, just wanted to make sure there wasn't any other feedback, so can everyone see and hear us okay? Okay, we'll take that as an okay, and if there's any difficulty along the way, please let us know, and we'll try to keep an eye on the chats down there. So I see lots of yeses, so thank you. Perfect. So yes, we're very honored to be here, and I'm sure there's lots of different individuals and organizations that are on this webinar that have already done a lot of great work themselves, and we hope we can kind of contribute to that knowledge, and hopefully at the end kind of maybe share some experiences that we both encountered along the way, and hopefully you may get to learn some new things, and in particular how we do this on an organizational level and implementation of trauma-informed care. So thanks so much, and we're going to start the presentation. So we're just going to wait here. I don't know if we just need the slides to come up. And as folks are working on those, I can just start. So Sue and I work at the IWK Health Center, and that is an organization in Nova Scotia, and it's a tertiary care health center that employs about 3,000 staff, physicians, volunteers. We're also a learning and teaching hospital in Nova Scotia, and we really pride ourselves on 3 primary care areas. So we work in with different teams across the health center. So we have 3 primary programs, we call them. So women's and newborn health, children's health, and mental health and addictions. And of course, we also work with many different operations and support teams within our health center, our IT systems, our kitchen staff, protection services, and different support people within the health center. So we do serve people from the Maritime provinces, so looking at Nova Scotia, PEI, New Brunswick, and sometimes also Newfoundland. So when we talk about trauma and trauma-informed care, I know that you guys are probably quite familiar with the definitions of this, but we really wanted to set the stage as to what we're talking about when we talk about first trauma. And we really did this with all of our staff across the organization because there were many different ideas about what trauma was. There are some staff that said, oh, trauma is the car accident, or when I go to the ER, or medical trauma. And we really wanted everyone to have a common understanding about what that meant. So really when we talk about trauma, for us, we're really talking about any event or experience that overwhelms a person's capacity to cope. And they could include things such as neglect or abuse, violence in the community, looking at, mental, physical, and sexual abuse, looking at an accident that may happen, and also looking at it from not only an individual level, so trauma may affect the individual, of course, but also we know that it affects the family, it affects the community at large, and what can we do as healthcare providers and in social systems to really say what can we do about trauma and trauma-informed care, and what can we do as a system. So that kind of leads into the piece about trauma-informed care. And the other thing that we really highlight to our staff across the IWK as we went on this journey was that we really wanted them to think of the definition we just talked about as trauma, but also thinking about in our healthcare systems that people may come into our environments experiencing trauma, but they may also experience trauma within our hospitals or healthcare settings or our different systems or teams. So really recognizing that that can also happen too, because it could have, painful or repeated medical interventions. For organizations that may use seclusion or restraint, they could also be dealing with that. So really broadening again when people could experience trauma and recognizing that everyone is different, we all have resilience, and really, one person experiencing trauma and another may look very different. So if we move into the trauma-informed care definition here, we wanted people to really recognize that when we're talking about trauma-informed care, we're talking about, again, that universal, strengths-based, universal approach to care that is rooted in that trauma is very common in our society. We know from the ACEs study and many other studies that it could be anywhere from 55 to 97% of our populations, with around 67% of experiencing one trauma in their life and many others with many more. And we know that the more trauma that they experience, the more health outcomes that could happen as an adult from having child adverse experiences, from mental health problems and issues to also physical health problems and issues, so looking at depression and anxiety, cancer, heart disease, so really really understanding that impact of trauma and it impacting on all the different systems within ourselves, emotionally, physically, spiritually, cognitively, so really recognizing that that can happen. And the great thing that we love about trauma-informed care is that it's emphasizing the physical, psychological, emotional safety, not only for our clients and families, but also for our staff, because I think that's a really important piece. So what are we looking at when we talk about a trauma-informed organization? So we're really looking at the pieces and the tenets, the principles and values of trauma-informed care. So in our organization, we're really looking at how do we create that safe environment in that physical and emotional sense. So how are we creating our waiting rooms, our bedrooms, our inpatient spaces, our outpatient spaces, spaces for staff, and are they physically welcoming and safe? But on the other end, are they also, we can have a beautiful room that looks very nice and is up to date, but also, the emotional interactions that happen within those walls, are they safe for people, do people feel that they can, you know, share what they're thinking and feeling and receive support that they need. When we look at trustworthiness, we're looking at as an organization, how do we maximize that? How do we make sure that our patients and families and our staff are clear about, you know, their stay here, what work they need to do, they know how to maintain appropriate boundaries, are pieces clear, and can they work on having those relationships that promote trustworthiness? Then when we look at an organization, we really want to make sure we're prioritizing choice and control, and to the degree that we can. So if we're thinking about a young person, a 5-year-old, maybe options for choice may look a bit different than a 15-year-old or 55-year-old. So how do we really look at that, looking at some developmentally appropriate pieces, and then also looking at the individual. When we look at collaboration, really looking at as an organization, are we collaborating, are we partnering with our patients and families and staff, or are we partnering with the larger community, and really recognizing that we're all in this together, and how do we create that environment and collaboration, which in the end is going to, you know, produce the best outcomes for everybody. And empowerment, looking at how to make our organization recognize skill sets and strengths of both our clients, families, and staff, and really build on those strengths. So again, recognizing, you know, the positives in everyone. So looking at our journey, so how did we get here? We had a review of our services done in 2014, and it was an external review that was done on child and adolescent mental health within the Halifax Regional Municipality. And it looked at our services and made some recommendations, 14 of those. And the top 2 were about trauma-informed care and trauma treatment. So the first one actually looked at trauma-informed care and said that, you know, you have really good individuals that provide trauma-informed care, and you have some really good teams that provide trauma-informed care, but as a whole system in hospitals, you don't do that kind of on a systemic way. So we really looked at what do we need to do that. So there was 2 streams of work that was done, and the first one that we'll talk about is work that the IWK did with the Department of Health and Wellness in Nova Scotia. And I'll get into that in the next slide. So what we did first is that we had a group of people across Nova Scotia that were interested in trauma-informed care and in figuring out how do we go about this. So we had an advisory committee that came together, and we decided, you know, we really need to get out into the community and find out what do people know about trauma-informed care, what do they want to know about trauma-informed care, and how can we meet their needs. So we went to various locations across Nova Scotia and asked people, what do you think about this? And as you can imagine, there were varying degrees of understanding. There were some people that said, I don't know anything about trauma-informed care. Some people said, you know, I practiced that, but I didn't know it was trauma-informed care. And then some folks that were practicing it for years. So we had a varying degree of knowledge and expertise within those rooms, which was great. So out of that, people said, we want to know more about what is trauma-informed practice, why is it important. We want to know what's the impact of trauma, what are the effects of trauma, and also looking at how do we apply trauma-informed care in various settings or with various populations, and then looking at how do we apply trauma-informed care on the agency and interagency level and systems level. So they were the webinars that we had initially in Nova Scotia over a 4-month period. And then after the webinars, folks said, you know, it's great to have the webinars, it's great to have this opportunity to view them later, but also could we have some kind of practice guide or some kind of tool to help us in our day-to-day practice that we could pull out, for instance, in a staff meeting. So based on those webinars, we designed some practice briefs, and they are available on the Nova Scotia Department of Health website and also on our Experiences Matter, yourexperiencesmatter.ca.com on our website. So, and we'll get into that, a little bit of that more later, but these are available, and they really get into the topics that the webinars discussed, and also have some discussion guides in there. So if staff want to take some questions to a staff meeting, they can, and have some conversation about that. We have lots of references, lots of web links, so lots of information in those that can be helpful for folks. So then the next piece is a piece that the IWK looked at. So when we think about trauma-informed care, and in the provincial work, we were mainly focused on child and adolescent mental health and adult mental health. But at the IWK, as I mentioned at the beginning of the presentation, we are a health center that provides care for women, children, families, along with mental health and addictions. And so as an organization, we had great support from the frontline staff and also from our executive leadership team to say that this is something that we want to do with the health center. This is not just a mental health issue. This affects everyone, and we all need to be trauma-informed. So there was a big support from our leadership to say, we need our volunteers trained in trauma-informed care, we need our physicians, we need all of our clinicians, support staff trained. So they really did send out an organizational-wide message saying that we were looking at becoming a trauma-informed organization, and Sue will talk a bit more about that in a minute. So looking at our vision, so groups of us sat down and thought about really what do we want to accomplish with trauma-informed care at the IWK, and looking at a vision for everyone to have. So our vision is a culture that understands trauma and actively creates safe physical and psychological spaces that improve everyone's experiences. Again, really focusing on this as a collective change and culture shift for us. And then our mission, looking at to embed safety and trustworthiness into everyday interactions, policies, and practices, and to acknowledge and understand the effects of trauma on people. When we also started out, we were looking at what do we want everyone to know. So regardless of your role in the health center, what are some key concepts? And these are some important things to think about if you're starting to roll out trauma-informed care. So as I mentioned, we wanted to have consistent definitions of trauma and trauma-informed care. We really talked about, because trauma is so prevalent within our populations, that we were looking at applying a universal precautions approach. So really looking at, anyone that we come in contact with may have experienced trauma, and how do we create those environments, both from a physical and emotional sense, that create, and embody those principles of trauma-informed care that we talked about. Our health center, and we also looked at what approaches we already used. One of them was patient and family-centered care, and really looking at how does that align with trauma-informed care, how do other approaches that teams are using align and maybe complement that, so people have an understanding of how they all fit together. So that was another important piece. And really emphasizing everyone plays a role. So we really talk about, working with our volunteers are the first people that many of our patients and families see when they come in our organization, and really the importance that they play in setting the tone for the whole visit. So really people have taken an ownership and accountability and saying, I have a role. There's some things, within organizations I don't feel I have a role in, but this is something that I do. So that's been a great start of this. Addressing the emotional and physical environments, focusing on trauma and resiliency, again, that balance and knowing that people may experience trauma, but again, they may have, great resiliency and support systems and are able, to cope. So recognizing that, again, that people have different experiences. And really looking at how we look at trauma on different levels. So again, the client, family, staff, agency, interagency, intersectoral and society level. So really looking at every level and how trauma-informed care and trauma can be applicable on those levels. The other big piece for us, and the other big piece that people really saw themselves in and felt free to have conversations about, was that we really stood by that trauma-informed care was really looking, half at patients and families and half at staff. So really making sure staff really knew that, as it says there, and I'll just read it off to get the full effect, but staff members, all staff members can create a setting of and offer relationships characterized by the principles of trauma-informed care only when they experience these same factors in the program as a whole. So really, how are they experiencing safety in their workplace, trustworthiness, choice, and collaboration? And it's only when they experience that and feel that they can also offer that. And really recognizing that when we talk to staff, it's that, yes, you are here, and that we want you to be well, and we want you to be well in order to provide safe, competent care, but it's also the piece of it that we want them to go home, we want them to have a great quality of life, great relationships, and a great work-life balance, so also focusing on those pieces too. Within the IWK, we knew that we had a lot of work to do and a lot of different pieces that contribute to a trauma-informed care environment. So we developed some advisory and working groups. And really with this slide it says, which it looks like, it might be a little complicated, but it is kind of complicated. There's so many people and so many groups that need to come together to make this happen. We have our trauma-informed care team, we have an advisory team, that really is comprised of different people within the IWK, our community and system partners, different populations and groups that have interest in trauma-informed care. So we've been really fortunate to get a lot of folks that have the same vision, different departments. So we have, you know, from health departments, Department of Community Services, Justice, Education are on that committee, different, as I say, community partners. So it's been a really great collective group that's been looking at this. Our clients and family is very important to have their participation and their partnership throughout this process and every level of it. So we're very conscious of that, how we can do that and how we can do that better as we go along. Community partnerships, and then also connecting with some of the folks that have already done a great job in this. And again, there are folks in this instance, such as Community Connections and the Trauma Center, which we're using ARC, and so we'll talk about that in a little bit. The other pieces that are really integral in this is really looking at our education, evaluation, and research throughout all of these, so it's really embedded through this model. Along with our advisory committee, we have 5 working groups. So one is looking at safe and secure environments. I'm just going to flip to the next slide. Go back for 1 second. So we have safe and secure environments, and they're looking at, again, the physical and emotional settings of the health center. They're looking at developing, you know, different checklists, different things of how we would look at policies, patient information packages, those sort of things. We have one group totally devoted to psychological safety and health of staff, and then also a subgroup that's looking at debriefing. So we're really looking at what can we provide in the health center as resources and supports, and some of the work that we're doing there, and we'll talk about that a little bit more. The model group was really looking at education. So what education do we need across the health center, and we'll share that plan with you guys. Early response and screening. A big one with this is that we started off looking at screening, and what we found out very quickly was that staff were saying, depending on the setting and area, of course, that they really felt that they needed a comfort level in order to have the conversations and know what resources were out there, and feel comfortable about having conversations about screening. So we really looked at how do we support staff to have those conversations, how do we make sure we have the resources for them, and then looking at what is our screening script. And then we have assessment and treatment. So I mentioned the other recommendation from the review was to look at how do we, as an organization, provide trauma treatment? Do we have clear care paths, clear algorithms? What treatment do we provide if someone is interested in working on trauma? So that's really the work of the assessment and treatment group. And as I mentioned and I talked about, all of these are wonderful partners that have partnered with us on this, and without them, really, we wouldn't be as far along as we are, because all of these groups provide such different lenses and different, you know, views and different ways and suggestions that we can become trauma-informed. So their participation has been amazing, and thank you to them.
Hi everyone, this is Sue. I'm going to talk a little bit about the various phases of the project, starting with sort of year 1 and what we accomplished, and then moving through, just to give you sort of a timeline and let you know where we are, what we've accomplished to date, and where we're going next. So really the first year was primarily about information gathering and planning. We had all these great people, all these wonderful committees formed, and everyone was ready to work. So the first thing we did was really look at doing a small environmental scan and a lit review to figure out exactly what other groups we're doing in terms of trauma-informed care, with a particular interest in if other hospitals were offering similar programs and or similar frameworks, and what they had accomplished. So when we were doing this, we found, you know, some of the work by Roger Fallon and Maxine Harris. We discovered the National Traumatic Stress Network, Dr. Vanderkolk, some of the ARC work, Sanctuary, all these different models, frameworks, and literature, and we started compiling all this data and really reading through it. And then at the working group level, we developed sort of research questions, things we were interested in, and started doing individual lit reviews by topic area. So it was a lot of people involved and a lot of data and information to go through, but it was really exciting just to kind of get a sense of what was going on around the world in trauma-informed care. While we were doing this work, we reached out to Community Connections, which is a U.S. organization that was started by Maxine Harris and Roger Fallon. And they had these really great working guides and implementation sort of guides that we wanted to learn from and use. So specifically we looked at their self-assessment and planning protocol, their services implementation plan, and their self-assessment scale. And we actually met with them and ended up having some members from the team consult with us and also come and do presentations here as part of our launch. We also found out about their certification program, which is actually a plan. We're looking to do this over 5 years where we can become a trauma-informed certified organization. Right. So the first step we took in that was trying to figure out our baseline at the IWK. So we needed to find out sort of where we stood in terms of how trauma-informed we were pre the launch of our whole movement towards becoming a trauma-informed care environment. So as Holly had mentioned, we knew that there was a lot of good individual work happening, that there were a lot of clinicians who were very specialized in trauma work and were providing amazing services. We also knew that we work in a very caring environment, so a lot of our clinicians who might not have formal trauma-specific treatment background or training were also, creating a very positive and welcoming and nurturing environment. But we wanted to get a sense of sort of some of the key things that are outlined in the principles of trauma-informed care and the behaviors and policies and practices that are sort of attached to those, and to see if any of that stuff was actually happening. And to record like at what level it was happening before we actually became trauma-informed, so we would have a baseline so we could compare and see how we're changing and growing year over year over year. So that started with our trauma-informed care organizational assessment. And this is really exciting. It was an online survey that we made available for 2 weeks to all staff, and we had some incentives for participation. And we in total got 877 participants, and it was really great to kind of get as I said, a baseline to see where people were. And we actually have this, I believe, on our website, this report, or we can put it on the website so people can sort of see what we found. Once we had that data collected, we were ready to launch. So the launch was the first phase in our education plan. So it took place in February of 2016, and it involved 4 large-scale sessions that were in person. Holly, myself, and guest speaker Dr. Lori Bayer from Community Connections gave sort of an overview of what trauma was, what trauma-informed care is, and the whole plan, the rollout plan at the IWK and what we were hoping to accomplish. And then for any folks that weren't able to make it in person, we offered a webinar as well. We had over 1,100 internal and external participants in these events, so that was really exciting. And we also talked about a big key component of each one of those presentations was trauma-informed care for patients and families, but also trauma-informed care for staff. As Holly mentioned, it was always a large part of every presentation. So I'm going to quickly go through the education plan. So level 1, this was a tiered program that our tiered education plan that our model working group came up with. Level 1 was for everyone. It was our sort of a universal launch. And as I said, it was held in February of 2016. So that was sort of over the course of a week. Trying to get everyone familiar. We also did lots of poster campaigns and different things to try to spread the word. The next phase was facilitator training. So this was, we wanted to build capacity among specific teams because we're a very large health center, and our primary trauma-informed care team was based initially out of mental health and addictions. We wanted to make sure that there was good knowledge and good uptake of trauma-informed care across all 3 of our primary systems or streams, so women's, children's, and mental health. So we knew that we had to embed people within all the different programs that actually were able to act as facilitators to actually give trauma-informed 101 and sort of act as champions. So we developed 2 sort of streams. We developed a facilitator training stream where we actually, how many people did we have participating in that overall?
We had about 19.
About 19 people. So 19 people who could actually provide a level 1 training across the health center so that we could have these people as resources and get ideally all 3,000 people on staff to at one point or another be able to attend one of these workshops. The next phase that we're currently still in is identifying the champions amongst each team too, and these people will have a slightly different role in that they will participate as in knowledge exchange, but they will also sort of feedback information to our group and be like ongoing communication people, but also collect some data with their group that they can bring back to us and sort of have a slightly more ongoing active role that goes sort of beyond facilitating and more about working as almost like extended team members. And then the other thing that we did as part of the Level 1 education was our website, which was launched the week of the actual education campaign in February, and it is sort of a living, breathing website where we're constantly updating information, and we hope that it will become a real resource for our community partners and for our staff. Okay. So just some timelines to give you a sense of all of the progress. All right, so we've done a lot of the trauma-informed care organizational and staff support sessions. So another thing that we made clear during our launch was that individual teams could contact Holly and I or anyone else from our team to actually set up a consult. And then we would actually go and do sessions with their specific team. And we've done many, many of these at this point.
Many books, yeah.
Many that completed and many books. So basically what that is we go in and we do a TIC 101, and then we really do some exercises around making it really specific to the team itself and how, how that particular, so if it's like NICU or if it's the emergency room, like what would trauma-informed care look like in your particular space? And it's really great for us because we're learning so much from all the team members and all the people who are working in other parts of the hospital that we don't actually work in. So it's been really, really helpful for our team, and I hope for the other teams as well. We also are developing checklists right now that individual teams can use. So we're going to be meeting with them to walk through the checklist and show them how they can use them. We're also creating these like priority setting tools and different things and action plans. So these consults are a way for Holly and I or someone else from our team to actually go into the various settings with different groups and walk through some of these processes. And again, it's helping us identify our champions as well. So level 2 of the education plan is so as I said, level 1 is for everyone across the whole health center and community partners as well. Level 2 is a bit more targeted. It's for designated mental health and addiction staff and then identified individuals from other teams. And that is where we actually are doing some ARC training. So ARC is Attachment and Self-Regulation and Competency Framework. Created by Margaret Blaustein and Christine Kinberg. And as you can see here on the slide, these are the various components of their framework. And we're just at the beginning of this phase right now, so we just in the last few weeks have identified who all the people are who are to receive this training, and we've actually done several training sessions in the last 2 weeks, I guess.
Yeah, in November too.
Oh, sorry. Yes, in November we did a complex trauma 101 and some training then as well. So back to the timeline. So really we did an ARC needs assessment with one of their staff members prior so that we could figure out sort of the best way to actually roll out ARC across mental health and addictions. And that happened in June. Then we started the training in the fall, that's right, in November, and we're just finishing it up now. The next phase of ARC is actually working with clinicians to do supervision. So we're in the process right now of scheduling all of the monthly calls to do case consultations so that we have staff being supervised. And the impetus for this happening quickly is because we got everyone excited and we got them to ARC and they learned all the framework, and we wanted to make sure that we went right into supervision as quickly as possible, or in the process of starting it now, just to keep that momentum high because people were excited and are excited about this. So we just want to ensure that things keep moving forward and that our clinicians really feel supported in learning and doing this work. Level 3 of the education plan is even sort of more targeted again. So it is for designated mental health and addiction staff and identified individuals and teams who are working very specifically with clients providing trauma treatment. So whereas the level 2, the ARC, could be for anyone who's sort of working in a milieu with the kids, this one is more specified to the specific clinicians who will be doing the treatment. And this is really going to be starting up in the next year or two, because we have a working group who is looking at all the evidence base for trauma-specific interventions right now and making some decisions about what direction we want to go in. And so all of that research and all of that work is going to inform what level 3 really looks like and how we roll it out. So again, the first year was really about sort of looking at all of the literature, looking at the resources available, and planning. We are still in the process right now of looking at a benchmarking project, which will involve doing phone interviews with different agencies across the US and Canada and possibly some other countries, maybe Australia and the UK, to find out what other groups have done in terms of becoming a trauma-informed care organization. And as I said, the majority of level 3 training, which will be the next large step, will happen in a year or so once ARC has been established and we've had time to do some supervision with our clinicians. So our communication plan, we really wanted this to stick, and we really wanted to have sort of some images and some logos that really stood out in people's minds so that they could immediately associate the IWK with this campaign and with this work. So we talked about it as a group for a really long time. Our logo. Lots of input. Yeah, and we did a focus group with stakeholders and back and forth. And what we ultimately came to was the phrase, "Your experiences matter." And we liked it because we thought we feel like it's validating, it's really inclusive. There's a lot, that it can encapsulate, and it can apply to patients, it can apply to families, it can apply to staff. And we think it can be strength-based, it feels supportive, so we tested it out with some, as I said, a focus group, and then we hired a branding company to actually create the look of the logo. And we've gotten some really positive feedback, and I think we're full steam ahead with it. Yeah. We're putting it on posters and everywhere. And around the same time, with the branding company, we actually developed a website, and it's yourexperiencesmatter.com. If you type in .ca, it will also direct you to our website. And as I said, it's a kind of a living, growing site, changing all the time. We're adding to it all the time. But really, we hope that it'll be a very useful resource for community partners and for all of our staff and for anyone else who wants to connect and network around trauma-informed care. And the key sort of message is that trauma is common, but how people respond to it is unique. Understanding your experiences and meeting your needs is important to us. So please do feel free to check that out and give us some feedback. This is just a little quick glimpse at the landing page. It has some fun features. At the bottom, there's a select your theme color. So you can actually change, because we wanted to give people choice. We wanted to embody some of the principles. So you can actually go and change the color. In the About tab, there's all the information about how we get started and who we are and what we're trying to do. Under Learning, there are tons of resources. That's probably the tab that we've developed the most to date. Lots of PDFs and videos and different things. We're going to be having like a little scroll eventually in the bottom with some upcoming events and different things like that's a little bit more interactive. We also want to put a few more interactive features in, but there's some really cool stuff. I think it's under Learning where we have, you can go in, is it Learning or? Yeah, you can go in and actually look. We had an illustrator create a page that shows what a less trauma-informed waiting room would look like. And it has sort of little icon things that you can click on, and it explains why, what could be improved about the space. And then you can actually click on the bottom, and it shows a new waiting room that is, more trauma-informed. And again, you can kind of look around and see how, like things like having at a reception desk, not having your computer monitor like facing the waiting area so people can read confidential information, those kind of things. And just caring about the environment itself, and not having torn furniture, having X's clearly labeled, having lighting. Like optional seating, making it so that not everyone has to sit right beside someone else, that kind of thing. There's all sorts of little things. So it's a fun feature, and I think it's I hope you access the website and give us some feedback. Okay. The other thing we did as part of our communication strategy was we created several posters. We plastered them all over the health center. This is actually one of our first original ones, and this is our most popular one in the sense that this is the one that really got people talking in the hallways. And it's, as you can see, it's about semantics and our words having power. So we have sort of an old way of thinking, which is more deficit-based, things, asking questions like, what's wrong with you? And then you see how like all of these various questions or phrases can be sort of be made more trauma-informed just by changing the language to make them more supportive and less problem-focused, less kind of shaming or so just to give a couple examples, what is wrong with you could be changed to what happened to you, or how are you coping with this situation? The conception that if someone's misbehaving, they're being, or if someone's being manipulative, not to call them manipulative, but rather to understand and see them as just trying to get a need met. Same with attention seeking. We've heard people say things like, oh, well, this person just has poor coping mechanisms, they just can't hack it or they can't handle it. And kind of flipping that on its head to think, well, no, this is a really strong person who has survival skills, and we should be supportive because obviously they're doing things the best they can and they're actually using some great coping strategies. The notion that people will, if they've had trauma, that they'll never get over it, that they're permanently damaged, and making sure that your staff see these posters that say, no, in fact, people can continue to learn and grow and cope quite well and recover. And then a big one, this one was probably the one that got the most interest from staff because they hadn't really thought of it, but the concern of, oh my goodness, I can't ask someone if they've had trauma. I can't screen, I can't ask because they'll get really emotional, they'll get really upset. And we just wanted to make it very clear that that's not actually supported in the literature. But what people have found is that talking about trauma without forcing disclosure, of course, actually gives people the opportunity to discuss, normalize, and learn coping strategies. And if we fail to ask about trauma with our patients and staff, then we just might be keeping that all silenced, right? So it's actually an important thing to screen for and ask people about. Okay. This is another example of one of our posters. And then we did a newsletter early on. This came shortly after the readiness tool, the assessment, the organizational assessment, because we wanted to be able to follow up and again keep momentum going. Hopefully we'll do another one of these soon. I think that's going to work. And now Holly's going to talk to you a little bit about sort of, again, trying to get folks to integrate all of this information and all of these principles into daily practice, making it really real for people.
So one of the first things that we did is we talked a lot about how do we get new staff that are coming in. So one of the first things that we did is integrate it into orientation. And we had that actually after someone spoke about patient and family-centered care, so it was a really good flow into that. And this is one of the slides, and as you can imagine, in general orientation, it's everyone that's kind of there. So we want to put on pieces that everyone could relate to. So really, we looked at some of the data that Sue talked about from our readiness survey that looked at, do people actually knock on the doors? And in some instances, they weren't. So we wanted to pull some of that information and say, the importance of knocking on the doors, the importance of working in partnership with people, creating those safe spaces, introducing yourself again, so saying, who you are, what you're there for, what you're going to do, to ask permission before, if you are a healthcare provider, before touching someone, having those respectful conversations. So really trying to focus on and really highlight there's lots of things that we can do as staff kind of across the board, and what are those things. So really, again, in general orientation from the beginning, saying you do play a role in this, and this is something that you can do. So looking at our programs, there's lots of great examples that we found out, and we continue to find out as we do this work. For example, in children's health, they're really recognizing, again, that many medical interventions are traumatizing, could be re-traumatizing for their clients and families. Looking at from, having chemo to going to the lab for blood work, we know many of our children are very scared of that, and really working with our pain team and different folks in the health center and saying, how do we do this differently? How do we look at distraction techniques? What can we do for the staff? Because we know that they're also, stressed when a child is very, very upset about getting blood work. And how do we help that whole, system to kind of, get this done in a way that isn't re-traumatizing to a client? looking at, in our merge, they really looked at the ABCs, so looking at airway, breathing, and circulation, to looking to the DEFs. And I know there's lots of different DEFs out there, but this one looks at distress, emotional support, and family. And that one's from the Healthcare Toolbox, which is a great resource if you haven't already taken a look at that. They have lots of different tip sheets and different things that you can get from there. And then looking at processes. So how do we change processes? How do we change even patient and family information packages? A lot of teams started to look at their information, and it was more, oh, you know, you can't do this when you come in, or you can't do that, and really changing our language to be more positive, welcoming, strength-based, because we often say within trauma-informed care, if you don't feel safe, nothing else is going to happen. And even more than that, if people don't feel safe, they're not even going to come here, right? So how do we really even change those first communications that we have with folks to even want to come to our organizations and want to come in the front door, sometimes when it's really hard and difficult moments in their life. When we look at talking to our OR teams, you know, they had great stories, and I'll share one of them quickly with you, but really looking at, you know, a mom that came into our health center, and they asked the child, why are you here? And they said, oh, I thought I was going to the playground. And so the nurse initially said, you know, I had really strong emotions about that, because I thought, why is this mom saying that to her child, and why didn't she discuss it? And then when they talked about it further, the mom had experienced a death in an adult OR in a fairly recent time frame. So then the nurse said, you know, I really thought about that differently, and I switched it to think about what do I need to do, or what questions should I be asking all patients and families ahead of time, saying, you know, do you need any help telling your 5-year-old what this OR, you know, experience is going to look like, you know, helping with child life, taking out dolls, those kind of things, explaining processes. So really looking at that piece, looking at, am I explaining who's in the room, what is, you know, happening in the room, and am I communicating these pieces to different members of the team, or am I just kind of keeping information? So how do we really share that important information? So again, we don't have to share our stories a bunch of times, but it can be shared and communicated. Within our women's and newborn health areas, they're really looking at the importance of really recognizing the impact of trauma, especially with sexual abuse or domestic violence, for an example, and really how that can affect prenatal care and childbirth, and also looking at really saying, you know, is it okay if I touch you? We're going to do this exam now, and really having feedback, you know, that definitely is moving in a positive direction. The other thing we're looking at is policies across the health center, and really looking at, for instance, taking infants into care policy. So how do we do that in a more trauma-informed way? So how are we supporting the mom? How are we supporting the child? How are we supporting the protection service staff, as with our Department of Community Services staff? And how are we really looking at that in a way, we know it's a very difficult situation, but what things can we do to make it as easy as possible? So looking at mental health and addictions, obviously we know definitely recognizing the impact of seclusion or restraint on our patients, really taking that seriously, and looking at alternate ways to possibly prevent those kind of instances. So really now we're focusing on our comfort rooms, what can we do, what regulation activities can children or youth do within our programs, what space do we have for them to do it, and if we don't have space, because some areas don't, really looking at, can we have comfort carts with objects that they can use for regulation and sensory items, so really looking at how do we do that. And the other piece of mental health and addictions is that we're really looking at how do we support that disclosure of trauma, because in this area we know that it could come up a bit more, maybe it's focus of treatment, so how do we support that, that moment for folks. When we look at our operations and support teams, again, they may be the first people that our patients and families come into contact with, and how that important that is. You know, if they're helping them with the directions, welcoming them to the health center, it makes a big difference for patients and families, and just gives them that sigh of relief that there's a friendly face in the mix, and that they feel that they can continue with their day, and that it's a safe place to be. So that really makes a big difference for patients and families. And really looking at designing spaces. One of our spaces that we're currently looking at is our women's and newborn health kind of main entrance area, and what we can do with that to make it a bit more trauma-informed and up-to-date. So lots of different literature, great literature out there on space design, and areas too that we're trying to work with our facilities programs and other programs to make sure when they're designing spaces too, these principles are taken into account as they design areas. We talked about the IWK uses a patient family-centered care approach. Now we're using a trauma-informed care approach. So really, this graphic really shows us how they are different and how they're the same. So really looking at, they do share a lot of common kind of principles and tenets, which is great, but then how is trauma-informed care a little bit different, and how do we look at, considering families' needs and strengths and cultural safety and competency pieces, which may be also a piece of an extension of the patient family-centered care. So we talked about our working groups and initiatives, and there's lots happening for sure, lots of great enthusiastic staff and partners that are working on this. Our safe and secure environmental checklist, this is kind of a picture of it, and it actually has changed since this one. We have lots of new information coming in. So we looked at an environmental checklist from a lot of different areas. We looked at some information from the BC TIPS guide and some work that Nancy Poole was doing at BC. We looked at some work that was being done within homelessness populations and creating environments that are trauma-informed in those areas. We looked at different checklists kind of across the board, and also took some of our kind of criteria which we talked about for community connections and what they feel a trauma-informed organization would look like. So we compiled all that great information together and met with our group and our patients and families and really said, does this encompass what we think a trauma-informed environment would look like? So this is a checklist that when we meet with the teams, we go through it with them, and they're actually doing one of two different processes. Some teams get all the staff to fill it out and compile it, and then kind of go over it and say, what are our 3 priorities for the year? And then other teams get maybe an existing group put together, or a group of about 10 to 12 people, and to go through it and again identify those priorities. So that's been a big piece of that, and we will put that up on our website too, so that way folks can have a look at that. The other big piece is a psychological safe and healthy workplace group. So they're looking at debriefing. What we found across our health center is a lot of pockets were working on debriefing in different ways, but there wasn't a collective group that was really looking at it. And the other thing we found is that people were looking at debriefing from the sense of an operational debrief, or do we have enough staff, on to take care of the patients, are the patients okay, or the families okay, but our focus of this is really, are we asking, are the staff okay? And are we not only asking when an incident happens, but are we checking in a week later, a month later to make sure to provide opportunity to receive help if needed? The other thing that we highlighted was that even us in the group really didn't know what all the resources were for staff within our health center, so we were and are still compiling kind of a resource list, so that way staff can go to this list to access resources that they may need. Another big piece that we looked at and that staff were very interested in was doing a staff mindfulness session. So we did our trauma-informed care group in October, November, and we're starting one in February with managers, mindfulness session, so we're starting that. And the hope is that we know, especially too in management roles, there's also various pressures from, both ends, and just looking at how do we support managers in the work that they do. And then also, when we do the staff mindfulness groups, we'll have management too that kind of understands what we're talking about when we talk about mindfulness, and also hopefully to support staff to attend those sessions. So that's been an ask from the organization that we're starting to roll out. And then looking at compassion fatigue. So that's another big piece. So we just sent 2 of our staff to the TEND Academy to receive the training on compassion fatigue, and are looking at implementing that over the next year or so. So there are some highlights from those groups. Early screening and response, again, we wanted to focus more on resources and for people to feel comfortable having the conversations, or if they did receive information about trauma or a disclosure. So really looking at what resources do we have for patients, families, and staff to support them in this work. And really right now we're looking at a screening script that is very broad as a start, and then kind of drills down a bit more depending on if we get into kind of the assessment piece of it. So when we talk about assessment and treatment, we're working on a care path algorithm currently as our current process and what we hope to see in the future. And we hope with our benchmarking study that will help us to plug in some of the more, research and evidence-based trauma treatments as we go along. We also have a lot of conversations throughout this work with patients and families that are really looking to see what priorities they have and how, we can address those priorities that come up with their patients and families.
So in terms of our sustainability plan, I'm just going to go through the highlights. As I mentioned, we are doing team-specific and community-based organization consults. We also have our facilitators now, and we're working on getting all of our champions. We've actually switched our IWK orientation and onboarding materials to include trauma-informed care. So everyone who gets hired on at the IWK now learns about trauma-informed care as soon as they come in for their onboarding. And we're looking at how we can incorporate TIC principles into our policies, so doing policy scans throughout the whole building, seeing how we can make the wording and the sort of parameters more trauma-informed. From an evaluation perspective, we're using the Community Connections Protocol for certification. So the built-in test, a tool that uses sort of external review to determine whether or not you are meeting sort of all the criteria for becoming trauma-informed. We also have our annual all-staff survey, which, you know, the first year was the readiness survey, but now it's kind of morphing into an organizational assessment, which will be done annually. We're in the process of developing core competencies. So a lot of other groups in the States have developed some really strong trauma-informed care core competencies. So I reached out to the authors of those various documents and got permission to sort of use those and modify them for our own needs. So we're building those right now. And they're tiered as well. And then we have our team-specific evaluation checklist. Potential future initiatives, we really wanted to do some work with our Human Resources Department to figure out, you know, how to build TIC into the initial conversations in hiring and sort of use it as an education opportunity too, to talk about trauma-informed care during hiring. And performance appraisals as well. We also would like to expand on some student and training and student research opportunities. That's a little ways down the road, just because we're still trying to get enough resources internally to make that a possibility. And then we're looking at working with our local colleges and universities to actually build trauma-informed care curriculums. So making sure that, so when folks come to try to get work at various hospitals in Nova Scotia and IWK specifically, that you know, our students coming in and our young professionals coming in actually know about trauma-informed care.
You know, the other piece that we should mention too is that looking at kind of movement and sustainability is that this work will also be going, we're currently with the IWK, but we will be working with the rest of the Nova Scotia Health Authority, really looking at first child and adolescent mental health and the pediatric units and emergency departments. So this work will be kind of growing across Nova Scotia as we go.
Tons of opportunity for research. Sky is sort of the limit. We started a few projects and we have a whole slew of other ones that we're interested in. Again, we're just trying to build up capacity to actually find people to manage this work because there's some great opportunities and we want to really get some. We already have the capacity to pull a lot of data that will be associated with the trauma-informed care work, but we want to do some more research projects as well. So this is just a list of some of our preliminary ideas and foci. And then lessons learned. So Holly and I can both there have been so many lessons.
Probably a lot more than on the page.
Yeah. It's been quite an experience, as you can well imagine, trying to get this all off the ground.
Yeah, so definitely the importance of having both leadership support and frontline support, everyone's support, because without either of those, this is not going to happen. I mean, it's great for our team, the couple of us, to say, we're all trauma-informed care, but if you don't have the buy-in of all those folks in all those positions, it's really hard to move it forward and to embed it into the teams and into the practice. And fortunately for us, we did have, as we said, a message go out across the organization from leadership saying that this was endorsed, this is what we're working on. And even before that, we had so much support from staff that it was really great. So there was lots of momentum there. So that way we loved it.
Yeah. Balance and flow. So just maintaining momentum because there is a lot to roll out and there are sort of gaps. It's been a bit of a balancing act, honestly. And there's some messaging that was really important to managing expectations as well, because so one thing that happened early on was we said we want to become trauma-informed, but some people heard it as we are trauma-informed, and we had to put the brakes on that and be like, no, we cannot guarantee that we are 100% trauma-informed all the time. This is a process, and there's a lot of learning and a lot of uptake that's going to have to occur over a long period of time, honestly. Just making sure that we kind of manage all that. And then the other thing was, because we were focusing so much on staff wellness, we had a lot of staff coming to us right away. Like, right away saying, I need this, and I am burnt out, and this is, so it was really figuring out, okay, so we've asked people if they're well, and now that they're telling us in some cases that they're not, some people, we have to respond. You have to be ready to respond. So we work really closely with occupational health, definitely, and our partners, and try to be as supportive and helping as possible. But it has been a real learning curve for us. Certainly when we started talking trauma-informed, people really came forward.
Mm-hmm. The other couple of ones is really looking at dedicated resource, money, people, and time. We know that some organizations are not going to have that, and it is hard to do off the side of your desk. I would say it's not impossible, but it just takes you a bit longer for sure, because I think looking back, and as we do these kind of presentations, what happened in a year, really, because it's only been a year since the launch. But really, you do need some type of dedicated resources, like my time is dedicated, parts of Sue's time, and some others on our team. We have Persona Carewanza, who helps out with our kind of training, some education pieces, and having that dedicated team, and even just people, to talk to and have it bounce off of and really kind of know trauma-informed care is really helpful in helping that. And again, pulling in all those people from the working groups in the community and really, using their expertise, because I mean, in the community and at our health center, there's tons of it. So how do you really get people involved and really learn from them? Competing demands and priorities. So yes, in any health center, there's going to be competing demands, and sometimes, you're the demand and priority, and other times you're not. So really kind of going with that ebb and flow of the work and things that come up and things that you can't predict, and just being really flexible and really, again, trying to model those tenets of trauma-informed care really has been a huge piece of the work, I think, because for us to do this kind of work and not kind of model that is kind of hypocritical in a way, and I think we just really recognize the importance that are a lot more self-reflective, and then we did our own mindfulness training and all those kind of pieces that, we really do have to embody this, and are we going to make mistakes? Sure, but we're really conscious about how are we creating that environment in our own interactions with people, and just really, because we need to model it for others to model it too, and it's people are really taking that into heart and are really trying to change the dynamics of their team or their team meetings or so on. So there's been real recognition, I think, and progress in those areas.
Talk a little bit about addressing assumptions. So one thing that we did hear a lot when we first started this was, oh yeah, we know. we're trauma-informed. We got it. And we were like, oh, okay, well. And so you just had to have a lot of conversations with people just to sort of make sure that we all were on the same.
What does that mean?
So what does that mean in your team and in your waiting area and in your department? And what we found was actually for some people it was very eye-opening, because they really meant, were unbelievably well-intentioned and were doing a lot of things that were very trauma-informed, but also doing some things that just weren't. And they, I think when we started going through a lot of sort of examples of what trauma-informed care looks like, specifically with the team consults, when they could really understand it within their context, they were like, oh my goodness, I guess I could have done that differently. And we don't want people to feel shame or guilt, because, we're all here to grow and learn. Exactly. Like you don't, until you kind of maybe have some of these things pointed out, they aren't that obvious. So it's been a real education for us and for everyone, I think, just kind of seeing how we practice and how everybody can make their work a little bit more trauma-informed.
Definitely. And I think the other thing too, along with that, is the other assumption of that if you provide trauma treatment that you're also trauma-informed, and lots of people are, but there's also just that assumption of it, right? So if I do trauma treatment, of course I'm trauma-informed, and then on some reflection is that I could do trauma treatment, but is it in a trauma-informed way? So really reflecting on that. Mm-hmm. So yes, so they are lessons learned. So I know we have some questions there, so I don't want to stop.
Yes, that's great. Sure. I want to, it's Linda again, and I want to thank you, Holly and Sue. And we do have questions, so if that's okay, I'm going to just present you with the first one. One of the participants was curious in hearing a little bit about why the date for collecting baseline info was after the date of the launch. If you could.
Oh, I'm sorry, I'm sorry. No, it was before the launch. There was a rush to collect it right before the launch.
Okay, well that clears that up.
Yeah. It's not quite baseline if you do it after.
That's right. Okay.
Yeah.
One of the other related questions from within our own team is, did you share the results of the baseline with the staff?
Yeah. So
So actually, you can go back.
one slide that actually showed it was a 4-page newsletter that we sent out to all staff that gave a high-level summary of the findings.
So that went out to an entire organization. But
yeah, this is just the
top
page.
yeah.
But it's 4 pages long, and it goes through all of the results.
Mm-hmm.
The reason I asked was just when you were saying some people thought, I made the assumption that we're there. We've already reached our goal. So that's why I was just curious if they have.
Oh, yeah. I think part of the problem was that when we sent out the newsletter that was the results of the assessment, I think, not everyone is going to read it. So you can't capture it, you can't force it.
No. One of the other...
We sent it out via email, we put copies around, we tried to disseminate it.
Okay. One of the other questions that came in was, what kind of awareness did the posters bring about? And do you have any sense of whether that awareness that came from the campaign led to change on the ground?
I think the posters, we sent them out prior to our launch and education session, so I think it piqued people's awareness just enough to get them there. So I think that's kind of how that worked. So I think people looked at the posters and thought, okay, I use attention seeking, someone said, yeah, I saw this child emerge, and I would say they're attention seeking, but I never thought about it that way. And we're like, okay, we'll learn more kind of education session. And I think that's why we had about 1,100 folks actually come from internal and external. So I think through the posters, I think raised enough curiosity, I would say, to kind of get them to the education session, and then those who couldn't would either kind of come to us and say, okay, what's this about? So I think there's a lot of buzz during that time, kind of saying, okay, at first, is this for me? And we sent out messaging like, this applies to everyone. We want your input. We want your help. So again, it was kind of communicating that. So I think it tweaked them enough to learn more information, to get more knowledge about it, that hopefully then it was integrated into practice. I don't think the posters alone did that, but I think it, again, kind of was a piece that kind of led people to learn more.
And it was one of the questions on the readiness tool was, have you heard anything about traumainformed? If so, in what the format? Have you seen the posters? Have you seen that we had TV monitors that were spreading the message throughout the health center? We asked sort of what people had seen.
Okay, thank you. One of the other questions was, what would be your recommendations of organizations that may be able to help other agencies or organizations that are interested in taking this same journey that you have?
Lots of things. I think we were fortunate because we did have some experts that we could tap into. It was a big thing, like community connections for ARC. The trauma center, we worked a lot with the provincial work with Nancy Gould from BC. So I think there's a lot of people that we tapped into to say we don't have this expertise yet, we're just learning. So really tapping into them. I think the other piece is really looking at, again, that buy-in from leadership and from frontline staff to really have that, because I think without that, it's really hard to gain traction in the way that you might want to. Yeah, and then just really reaching out and seeing, who are the people that are already interested, kind of your early adopters of those kind of things to start off with. And change takes time. We definitely say that a lot. That this is a culture shift, that it's not going to happen overnight. But if there are people that you can kind of gain that momentum and interest within your organization or group, and kind of getting people together to have those conversations and learning from one another, and anything today that we've shared, we're happy to share with the group and post it on our website or email it to you or whatever way you'd want, because we know in a way we were very fortunate that we did have resources attached to this, and we know some organizations and community groups will not have those resources. So you don't have to start from scratch. If there's some things that you would like to, use or modify, we're happy to share that. So I think that, again, too, is not, if you don't have to start from scratch, don't. And, utilize the resources that are already out there and start it and make it useful for you.
Thank you. Another question dealt with structural violence, and I don't know if you were able to tune into the last webinar, but it really did focus on structural violence.
Yes.
And wondering how you've built that in and raised awareness specifically about the impacts of structural violence.
Yeah, so definitely, we're definitely aware of that, and even in our conversations about what is trauma and violence, really embedding that within the conversations and really looking at, you know, even with our structures and looking at the cultural safety piece is one piece in particular that we're very conscious of, and really saying, you know, what are we looking at? How are we treating all of our employees? Is that done, you know, in a way that is, you know, trauma informed, and are we, you know, really modeling what we're saying? So really, I think it's been definitely a focus in working with different community groups and saying, you know, how do we address that? And really, I think it's a big reflection, I think, on ourselves as individuals and as organizations, saying where are we at with that? Do we see it in our policies and our procedures? Do we need to revamp these? What are these looking like? Because, as you know, in some organizations, their policies and procedures can be very old and they're not re-looked at. So how are we looking at those pieces too?
Another question was, can you share some of the resources you are using related to the mindfulness training that you mentioned?
Sure, so we can talk a little bit about that. So I think if there's anything we can share, we will share. So we partnered with Dr. John Lovis, who works at Athabasca University, who actually teaches courses on mindfulness-based stress reduction. So we actually started with him using that mindfulness kind of piece, and we had him do it actually with us, so that way, because we thought as our trauma-informed care team, if we weren't really sure what it was about and how we promote it and so on, so to walk the walk, we took it, and it was really great, like almost honestly life-changing experience where you really learn, you know, how does, you know, really being mindful and how that affects you, you know, personally and professionally, and how we can be in the moment and authentic and, you know, not leading those dual lives and all those kind of things that we want to be our authentic selves. And I think that has been really great, and he's been, you know, a great person to work with and mentoring us and really looking at, you know, how do we do this in the organization. So yeah, there's definitely online. He actually has a blog too, that if you're interested in that, if you look at his name, there's lots of information on mindfulness and the mindfulness-based stress reduction that he does and different pieces there, so you can always check that out. Yeah.
So maybe what we'll do is get the exact spelling of your contact's name and then be able to share that with the participants in the webinar. And
perfect. Oh, we lost the sound there. We can't hear. Sorry.
Oh, one final question, because we are running out of time, and just to say that people are very interested in the questions and answers and have asked if they will be available as well as part of the recording. And my belief is that that is the case.
Oh, sure, yeah.
Okay, if that's okay with both of you. So the final, okay, great. The final question is, do you see applicability of the kinds of training that you've been incorporating for women's shelters throughout the country?
Oh, definitely. We actually have partners within the women's shelters within our community that have attended the training and have found it very helpful. I've already been a leader in trauma-informed care, as we know, for many years now, so really partnering with them on how we both support each other, because I think, again, with an organization that has resources, we've been very conscious about how do we share those learning opportunities and really how do we partner together to both, you know, benefit from different things and different expertise that we have in our area. So, yeah, we've definitely been great partnership.
Yeah, and there's a large body of literature out of the U.S. on how trauma-informed care has been, you know, has had a real presence in women's shelters specifically, and in social service organizations as well throughout the U.S. So, you know, a lot of women's shelters have adopted trauma-informed care as one of their principles. Oh, we can't hear you again.
I am so sorry. They tell me that I'm not doing a good job of clicking the talk button. It just takes a little bit of practice. I just wanted to, on behalf of our entire team, to thank you both so much, and our participants, for just being so open about your journey and where you're at with that journey and the lessons you've learned, because I think it is inspiring to all of us, and the fact that you let us know that while it's exciting and inspiring, it's also a lot of work, and that it really helps to be able to share and learn from others as we all aspire to move in this direction. So Holly and Sue, thank you both so much. And to our participants, please look for that message from Sarah with the evaluation link. And in a short while, within a couple of weeks, the websites where you'll be able to find the recording of the webinar and other resources that names, information that people have asked about that we'll include on that web page. So again, thank you to all, and we hope that you will join us for our next webinar that's coming up that we'll write to you all about. So thank you, and we'll say goodbye.
Thanks so much, everyone. Take care. Bye-bye.